Hey, good morning. I'm Pam Naylor, and I'm here to talk to you today about observation. When patients come in the hospital, they are either put into an inpatient status or an outpatient status. If they're outpatient, they're considered observation. Most nurses don't pay attention to how we get reimbursed, and you don't need to. You're taking care of the patient because that's really what you're hired for and to be more important. However, on the back end, it is important how we get reimbursed, and that's, like I said, why it's important. Inpatient status, we have bundled payments. It's considered a DRG, and there's certain categories. Outpatient, we get actually billed for different types of services. Okay, surgical patients come in the hospital and they are usually put in an observation status. Most surgeries anymore are considered same-day surgery cases, and they're considered outpatient. We've changed a lot of things in the last 2 years. Knee surgeries, back surgeries are now considered same-day surgeries. So they are not true observation. A true observation patient is when somebody comes in the emergency room, the doctor isn't sure exactly what's causing their issue. Up to 48 hours they can be in before we either admit them, send them home, but they're trying to figure it out. Surgical patients, before, I'd say probably about 4 or 5 years ago, we put them in an observation status, but we really know what they're here for. So we don't really bill true observation hours for them. However, we do count the time, and they are considered outpatients, and we can bill for other infusion services separately. True observation patients are when, as I said, somebody comes into the emergency room, we don't know what they're here for. It could be somebody with CHF, it could be somebody with shortness of breath, it could be somebody with chest pain. We don't really know why they're here. We get paid for up to 48 hours of observation time by almost all insurances. It's sometimes a bundled payment. However, once they reach the second midnight, we either usually admit them or we try to send them home. But all their services up to that point are considered outpatient. On the last slide, it showed that also there was a comment about the CMS started the 2 midnight rule, and that was started in 2014. It makes a difference because CMS, which is Medicare, basically said in 2014 that if somebody comes in and they're here for less than 2 midnights in the hospital, they should be considered an outpatient, not an inpatient. And prior to that, what they were doing is having RACs, which is another agency that they hired, that would take and look at the short inpatient stays, and they would subtract money back and they would audit. So now observation patients are pretty much, if you come in, if you're not in for 2 midnights within the hospital, they really want you, almost all insurances are following the Medicare CMS guidelines. They want you to be considered an observation patient. Observation patients can be changed to an inpatient status as they approach the second midnight. The case managers at our facility review all the cases with the physicians, and as they approach the second midnight, they either try to admit them or they try to send the patient home. We monitor all time that the patient's in here for observation. We count that. We track the hours. If somebody's in for more than 2 days as observation, which does happen, say we can't get placement for them, they can't go to a nursing home, it's not safe to send them home, but they're really not sick enough to be considered an inpatient, we still track the hours. We can't bill for that, but we still track the hours because we want to show the facility's use of time and resources to take care of that patient. Documentation and observation is very important. It is a crucial factor in to get the times right and what we need to bill for. One of the things that we use for documentation is we do essential documentation for IV infusions, and they're essential infusions. We need a start time and a stop time. If not, I can only bill as an IV push. When you scan the medication, that is the start time. When you end the medication, it also usually has to have a scan or a time entered. Sometimes it can be skipped. There's a prompt that comes up. Pharmacy has worked with me. We've got that pretty much a prompt. However, if you skip it, you can always enter it some other form of fashion that I can find, maybe documentation in the nursing notes. But if I see a trend, I can contact the nurse involved and just say, hey, please try to do your stop times. I can only bill for a push rather than an infusion, which is about $100 difference in reimbursement if I don't have the stop time. Another thing that we can bill for at the bedside is bedside procedures such as Foley catheter insertions, thoracentesis, Sometimes paracentesis, but we don't generally do this at the bedside. Spinal taps, all those things can be billed for separately besides their observation time if there's documentation. The other thing that's crucial is when the patient is off the unit. If they go down for a scan or an x-ray or any kind of procedure, we have to carve that time out of the observation. We can't bill for observation time along with their procedure that they had done or their scan off the floor. Okay, on infusions, we need a start and a stop time. I'm not looking for start and stop times on maintenance infusions, like 100 cc's an hour for 10 hours or 125. What I'm looking for is medications that we give, antibiotics, magnesium, potassiums, that type of thing. We need to have a start time, which is when you scan the med, and then a stop time when the med is actually completed. Pharmacy does have it on the MARS, like the suggested times, but we don't hang our meds exactly at 10 o'clock. We may hang them at 10:05. However, you can enter them in or you can scan them for the stop times. It usually now shows with the new Meditech, it will show a 0 volume, and that's usually how the stop time gets documented, when you show that the volume for the infusion is 0 and it's reached its completion. As I mentioned earlier, we can document and we can charge for any procedures that are done at the bedside. That includes Foley catheters. Sometimes we put chest tubes in at the bedside. We do thoracentesis at the bedside. Anything that is not routine, we can bill for separately. I also mentioned previously that when a patient is off the unit and they're not on the nursing floor, we cannot bill for that time. We actually have to carve out that time. So if they are not on the floor and they're going down for a procedure, a cardiac cath, an x-ray, a CT scan, we carve that time out because we cannot bill observation time when they're off the floor. When a patient is in observation, I ask that the nurses document at least once a shift every 8 hours in the nursing notes. That is not the assessment, that is not all the other checks that we do on the patient. If your account's being audited, put your auditor hat on and think about it. If your account's being audited, you want to see how the patient's doing. Are they doing better? Are they doing worse? If they're in for shortness of breath, is their breathing relieved? If they're in for pain, is their chest pain better or is it worse? Is their pain medication working? You want to see if they're making progress to their discharge, and either whether we're going to admit them or they're getting better and we're going to send them home. So at least document at least once every 8 hours in the nurse's notes, please. Hopefully this made some sense at all about why we have to document differently on observation patients. They are mixed in our general population. In the house, we don't have a dedicated observation unit. If you do have any questions though, you can reach me by email or you can reach me Monday through Friday at my office. And I hope you guys have a good day and welcome to Mountain Itney.